Hi, everyone. We're just giving another minute or so until attendees arrive, and then we'll get started. Okay. Perfect. I think we're good to go. Hi, everyone. Good morning. Good afternoon. We are Malama Health and are so honored and excited to be presenting today at the National Maternal Health Innovation Symposium. We were attendees last year in Chicago, and we're so excited to be back this year presenting and being able to share some of our data and learnings over the past year. Malama Health is a small company with a big mission to improve pregnancy-related outcomes. We're focused first on the most common metabolic condition in pregnancy, gestational diabetes, which affects nearly 1 in 5 globally, and amongst Medicaid populations where we're focused, nearly 1 in 3. So a quick overview of some of our learning outcomes today. We'll give a quick background, current standard of care for diabetes in pregnancy, share some of the research around growth, risk factors, why we've seen, quote unquote, an explosion in diabetes over the past few years. And then Daniela will take us through a quick session on designing for inclusivity and equity and critical principles to keep in mind when designing for the populations we serve. And we'll leave the last 5 minutes for Q&A. So quick background here. My name is Mika Eddy. I'm one of the co-founders and CEO for Malama Health. We're based here in the Bay Area, although we now serve over 2,300 women nationally and also have a couple patients ex-US as well using our platform to manage their diabetes. I had diabetes in pregnancy. The first time I was diagnosed was in 2020. I was serving as the Director of Clinical Product Innovation at United Healthcare and Optum. And by day, I was working on bringing latest technological innovations to improve access and delivery of care. And in between meetings, I'd be pricking my finger. And for those who are familiar with the diabetes protocol, writing down everything I ate on a piece of paper and trying to figure out how to best transfer records to my care team. That was 3 years ago. I have a 3-year-old little boy who's healthy, who we're very grateful that everything turned out, but we know that this is not the case for many women. And the rest of the team came together around the same mission to improve the standard of care, reframe the patient experience from one of isolation and anxiety to a positive and perhaps even delightful experience, which we'll talk about today. Here I am on the right. 2 things that struck me with managing my diabetes in pregnancy. One was the enormous bill sent to my health plan and the large copay. A diabetes pregnancy is 3 times as expensive and costly for the health system as a low risk or no diabetes pregnancy. The second thing was that we found in my case, we were using pen and paper, and that this is common across over 90% of the clinics and hospitals that we work with today. We're all still using pen and paper to manage diabetes. And pen and paper in and of itself may not be too surprising, but the fact that patients need to travel sometimes up to 2 or 3 hours just to bring in records in order to get reviewed and receive education in between visits with the maternal fetal medicine specialist or OB is what struck me as a large opportunity for improvement in the patient experience. Wanted to share a quick story from one of our patients as we talk about increases in gestational diabetes rates. So within our Medicaid populations that we serve, an estimated 1 in 3 are diagnosed with diabetes in pregnancy. And if we move downstream, an estimated 20% of all women with type 2 diabetes have had gestational diabetes previously. That's 1 in 5, and considering 1 in 4 US healthcare dollars today goes towards diabetes, quickly becomes a very significant cost. And diabetes in pregnancy also has a lifelong impact on mom and baby. And we want to share the story of one of our users, Anna, who is one of our over 2,000 moms that has been using Malama to manage her gestational diabetes. Anna is Mexican-American. She lives in Florida and is a third-time mom. This is her 3rd time with gestational diabetes. She found Malama on the App Store and thought it catered to moms who want to be more detailed. She also likes the visuals and progress page that Malama offers. Malama is also the only app designed by maternal fetal medicine specialists, as well as moms who had gestational diabetes. Anna's used the syncing function to pull all her data in from the glucometer and likes the lifestyle changes and motivational insights that Malama provides. Specifically, one real-time tip told her to stand up for 10 minutes every hour, and she's already seen the effect on lowering her blood sugar. She also likes Malama's image recognition, is culturally inclusive, and says she didn't have to explain the content of a chicken fajita. So now I will transition to Shamali, who will share a bit more about research and some of our data.
Great, thanks, Mika. Before we do this little interactive portion here, I just wanted to introduce myself. My name's Shamali, and I worked on research at Malama. I'm currently in the final stages of wrapping up my PhD in epidemiology at Stanford, where I focus on maternal health and equity. So this has been a really important issue to me. My dissertation looks at health services and how racial ethnic disparities and class disparities impact usage of health services like C-section and abortion. And so a lot of those sort of insights and skills came in handy when thinking about equity at Malama. I also think I'm excited that I got handed the Q&A quiz section of this, because that is very much my life in grad school right now. Omika, could we go back to the screen share, or would you like me to share from my end?
Yes, no, I'm sharing. I'm just pulling up the Slido so the participants can see.
And so while we get that, so we're going to request that folks, you can scan the QR code, or you can go to slido.com and enter the code that you'll see shortly. And I'd love to get a sense of what people think for this question, asking which ethnicity has the highest rate of gestational diabetes.
Perfect. So this is a live quiz. We see some joining. We'll get it started. Here's the first question. Ten seconds.
We see our drum roll. About 38% voted for non-Hispanic Black, 35% for Hispanic, 3% for Asian, and 23% for AIN. So it's really interesting. I think in general, these guesses track with overall sort of health conditions in maternal health. But I think what's really interesting is that the majority of people got it wrong, which is so the highest proportion, the highest rate of GD is found among Asian, American, and Pacific Islander individuals. And the next question is, how have the rates of gestational diabetes increased over the last 4 years, or 4 years from 2016 onwards? And this was actually on a slide, so we'll see who was paying attention. And the correct answer is 30%, which the majority I see caught on Mika's slide earlier. So that's great. So yeah, before we move on, let's maybe look at some of the data. Here we have data from the CDC Vital Stats, a really comprehensive national resource for overall health, especially maternal and neonatal health. And we see that the highest prevalence of gestational diabetes in pregnancy is among non-Hispanic Asian populations. But we also see elevated rates among Pacific Islander populations and American Indian Alaska Native populations. Gestational diabetes is really characterized as a disease of the disparities, where we see these underserved or disenfranchised populations overwhelmingly having a higher prevalence. But there's also this interesting sort of genealogic difference. And then on the chart on the bottom, we also see that we have these disparities and they remain constant over time, but the prevalence is going up. And that's really what the next question was getting at. We've seen a 30% increase in gestational diabetes from 2016 to 2020. And I'm sure that that will only increase with the influx of data from the more recent years. And what this chart really shows is that over time, the prevalence has gone up between age groups, but we also see that older mothers are more likely to have gestational diabetes, which is a concerning trend given the average age of childbearing is also increasing in the United States. Could we go to the next slide? Perfect. So GDM, gestational diabetes mellitus, or GDM, is GD, as I'll refer to in this for the next few slides, is more than just a condition that impacts you in pregnancy. And I think this is a common sort of misunderstanding that it is something that impacts you during pregnancy and then life resumes to normal. During pregnancy, GD increases your risk of requiring an emergency C-section. And this is something we want to avoid, firstly, because we want to avoid unnecessary sort of surgical intervention, but having a C-section predisposes you to subsequent C-sections down the line. So avoiding that first C-section is a really important quality intervention metric, and GD increases the risks of needing a C-section. There's also a higher likelihood of preterm birth, which has implications for the for baby down the line. And then the lifelong piece of GD really manifests as these metabolic abnormalities, which could sort of infect hormones, thyroid, as well as type 2 diabetes being the highest risk. And then there's also an increased risk of cardiac defects that I'll share some data on in the next slide. The disparities fit in, could we just go back one step? The disparities piece really fits in when we consider the typical Malama user. They are primarily newly insured on Medicaid. They are often engaging in a health system that is predominantly in English when that is not their first language. They have a lower both literacy rate and a lower health literacy rate, which is particularly important because GD is such an intervention heavy condition. You have people who are diagnosed with GD having to change their diet and lifestyle virtually overnight for both their protection and for their baby. They have limited transportation options, and GD requires that you have to come in for at least bi-weekly visits. And then they're often following a non-Western diet. And so they're receiving advice like to cut out all rice from your diet when that's predominantly how they're getting their carbohydrate source. So back to the point of the lifelong risk of GD, women diagnosed with GD have a 2x higher risk of cardiovascular events postpartum. And what that means is just conditions that weaken or damage your heart muscle and heart function. So very, very serious conditions. These are sort of data from 2 recent studies that showed that being diagnosed with GD put individuals at this higher lifelong risk of cardiovascular events within the first decade postpartum. So at this point, we've kind of covered how GD impacts both lifelong in terms of cardiovascular events, but also in terms of type 2 diabetes. And so really putting various pieces together, we see that gestational diabetes presents very many complex challenges, both for patients, providers, and for the health system at large. And we've outlined just a few here. Mika, would you like me to go over these slides, or do you want to step in?
Yes. So thank you, Shamali, for presenting the data. I'll go through these quickly so we can get to some of the design principles, our learning outcome 3. But this is the key challenges around that Shamali highlighted in the last slide. Also open up an opportunity, particularly given we're at a time with large language models, continuous monitoring, including the first continuous glucose monitor, which was FDA approved for use in pregnancy at the end of last year, the Abbott Libre approved for use in pregnancy earlier this year, underscoring this unprecedented opportunity to apply new technologies to allow for personalized feedback, patient education in between visits, and of course, earlier interventions. So Malama empowers providers and educators, as well as patients, to help patients in between visits with real-time personalized insights that help to educate users towards healthier behaviors. Malama's platform is designed specifically for and not adapted to needs during pregnancy and postpartum, so specifically around checking 4 times a day with fasting and 3 postprandials, as opposed to type 2 or type 1, which have different methods of care and different thresholds. And also Malama includes culturally adaptive content, as we alluded to earlier through the patient testimonial. Here's a quick sample of some of the insights we provide. We'll also share at the end of this presentation a link to the application that you can download on either iOS or Google Play if you're on Android, and activate. And thank you for the question, Catalina. Malama is available in multiple languages, today English and Spanish. We have other languages, including Mandarin and Vietnamese queued, and would love to hear what else is top of mind for you. So here's some of the outcomes data, also available on our website. Just to touch on some of our preliminary user data, we've seen so far over 80% of our users achieve glycemic control within 2 weeks, and that 73% of our users actually stick with us through delivery. And Danny will share a bit more on that now. Transfer to you, Danny.
Thank you, Mika. Hi, everyone. My name is Daniela Bahamon. I am a designer by trade. I am also the voice of our patients and the voice of our providers within Malama. I love understanding all of the details and all of the reasons why there is a complex web of obstacles, and see how we can design around them to solve them. So we wanted to share the case study of a nonprofit 14 hospital AMC on the East Coast that has been piloting Malama. NPs run the perinatology clinic. It's an urban population. They see an average of 150 patients monthly. They have a standard of pen and paper. Primarily, their patients have come from multiple backgrounds, multiple ethnicities. They have different levels of understanding and interaction with nutrition and diet, depending on the CDE access that they've had prior. And there's a low postpartum rate of return, which is 10%, which is a big hurdle for continuum of care for moms. And after the NP team got onto Malama and was able to remote patient monitor their patients, the results were a 73% retention of their patients, an average logging of 3.2 logs per day, and 53% data completion, which means that we have both blood glucose and meals. And they shared with us in their testimonials that charting used to take 45 minutes, and now it's down to less than 5 because they're no longer chasing behind logs. And when they changed their standard from Malama back to pen and paper, as some NPs moved, their patients were quite upset when they told them that they would no longer be tracked with Malama, but they would be tracked by pen and paper. So quite encouraging. And the second case study that I wanted to share, which is one that's close to my heart, is a 700+ bed public tertiary hospital in California, Northern California. 90% of the patients are on Medicaid or uninsured. It's mostly a Latino population. 30% of pregnant patients have diabetes. And so they see pre-diabetics, type 1, type 2, and gestational diabetic patients, which adds to the complexity of their patient population. They are on pen and paper, and they have a big group of they have a big group of
A large Medicaid population.
a large Medicaid population. Thank you. Go on, Mika. So
Sorry, it was clicked through.
No, that's okay. Sorry. Please go to the next. We can go to the next slide. So how can we design for inclusion, equity, and inclusion? I'm an instructor in the design school at Stanford, and I wanted to share with you the human-centered design philosophy framework, which is one that any one of us can use to redesign any experience that we think should be redesigned. And that could be when you're sitting in the DMV and you're like, this could really use an improvement, or where you're thinking about your patients and you're thinking, how can we redesign this and how can we find a solution? And so what I wanted to do is to share this framework with you that we apply to any problem, and to show you how we've applied it to changing and redesigning the gestational diabetes experience, both for patients and for providers. And there are 4 steps to tackle any challenge. The first one is you start by getting empathy, and you do that by interviewing and digging deeper into what exactly are the problems that everyone is facing. Second is you take what everyone tells you the problem is and you reframe it. And you reframe it into how do we find also what is the real problem, what is their real need. The third is you ideate. We generate as many solutions as possible, and then you choose the best ones and you generate alternatives to test and create experiments on which you will rapidly iterate. And the fourth step is a bias towards action. Try it out, build and test it, and then go back and iterate again. And so how does that mean? How does that work out and deploy in this clinic, which is Santa Clara, or this pilot in Santa Clara Valley? They have a very complex team, RDs, MFMs, LVNs, NPs in 2 different locations and 2 different sites. They, as Shamali shared, deal with patients that are Medicaid, English as a second plus language, lower literacy rate. So we spent a long time shadowing all of the team members during appointments, in between appointments, during low downtimes, during charting. We have a lot of patient interviews, and we also do short surveys where they just interact with the app and they let us know, so they're unbiased. The next step is we reframe the problem. So if you look at every problem of every stakeholder in the team, they will tell you, the RDs will tell you, my problem in the first appointment is that my patients have an information overload. There is no way they can take and act upon so much information, but it's critical that they do. They repeat the same thing over and over every hour with every patient. NPs will tell you, I have a big issue with a lack of compliance for my patients, and every follow-up I don't have a complete picture. LVNs will tell you, I spend so much of my time chasing logs and getting them to send me my glucometer, double checking. And MFMs will tell you, I'm really concerned that all of this struggle leads to team burnout. So what do? We ideate around how can we solve each one, and we reframe the problem from an app that like an app as a solution will only work for my patients that are already compliant. We're not helping the ones that need the most help, to say, actually, an app empowers the patients for whom pen and paper doesn't work and get them to a 4 times day log objective. And so after ideating and iterating on how could we solve these, we build and test and we iterate upon what our app looks like for our patients, which means that we are alleviating information overload by giving them information in between visits. So we are the repetition, so the care team doesn't have to do it. For lack of compliance, let's take the onus of logging away from the patient and let's give them a quick 1-picture snap in order for them to log their meals. It auto tags ingredients. They are able to identify quickly, and it really just makes the repetition of the logging just so much easier. You connect real time with our care teams so that they no longer have to go in for each patient and calculate percentage in range, but all the information is available at their fingertips with a quick cut and paste button and seamless integration into the EHR. So they are no longer spending half of their time charting, but they get that time back in counseling. And from this pilot, we have seen really encouraging preliminary results. Patient satisfaction metrics are great. We get a 9.7 out of 10 for our app being reliable and convenient, which are 2 very important outcomes for moms, and feelings, perceptions of how they're being cared for. And then we're getting the 3.3 average glucose logs per day. 4 in 5 of our users achieve glycemic control in an average of 2 weeks. 80% of patients for whom this app is offered adopt Malama, and 90% of reduction time. So if you want to learn more about our tool, if you think that this is something that could be a resource for your communities, and that it could help us improve maternal and neonatal outcomes altogether, please get in touch. We are sharing this QR code so that you give us your information, and we will get in touch and find ways to be of service to your communities.
Thank you all for participating. We're happy to answer any questions we couldn't get to. Thank you, Catalina, for the questions. We are fully HIPAA compliant. We work with industry-leading partners in order to implement our data security and data privacy practices, and happy to share more. There's also references and resources available on our website at heymalama.com. Thank you, everyone.